Welcome, future nurses. I'm your instructor, and we're jumping right in. Today's explainer is a high-yield clinical review of critical neurological disorders, all geared to get you completely ready for the NCLEX. We're going to break down these complex pathologies into clear, actionable nursing priorities. That way, you can walk into that exam room and eventually your actual patient's room with absolute confidence.
Here's the clinical syllabus for today's rounds. We'll be systematically covering 5 critical areas: increased intracranial pressure, head injuries, meningitis, seizure disorders, and finally, hydrocephalus. Make sure you pay really close attention because we're going to test your recall right at the end with a 5-minute rapid-fire challenge.
All right, let's dive straight into Section 1, Increased Intracranial Pressure, or as we usually call it, ICP.
So ICP is a truly life-threatening increase in pressure within the closed bony vault of the skull. Because the skull literally cannot expand, any extra fluid, swelling, or blood leaves the brain with absolutely nowhere to go. Now take a look at the stark contrast between early and late warning signs here. Early signs, they're incredibly subtle. We're talking a slight change in the level of consciousness or maybe some visual disturbances like diplopia. But if you miss those, well, you hit the late signs, which include severe bradycardia and abnormal posturing. And at that point, medications like osmotic diuretics or corticosteroids become absolutely critical to reduce that cerebral edema.
Now, when we talk about abnormal posturing, it's crucial to understand the severe dysfunction it points to. With decordate posturing, the patient's arms are flexed and brought inward toward the core. This indicates severe dysfunction of the cerebral cortex. On the flip side, we have decerebrate posturing. This is where the arms and legs are in rigid extension and pronation, which is a really ominous sign of midbrain dysfunction. Make no mistake, both of these are absolute medical emergencies.
So, what are your priority nursing interventions here? First and foremost, you have to closely monitor that level of consciousness. It's always your earliest indicator of neurological decline. You also need to maintain the patient's head in a neutral, midline position. This avoids jugular vein compression, and elevate the head of the bed 15 to 30 degrees to help with venous drainage. Oh, and keep environmental stimuli to an absolute minimum while immediately initiating seizure precautions.
Moving right along to our next clinical concept, Section 2, Head Injury Management.
These injuries result from mechanical force, and they can be open, meaning there's an actual skull fracture of penetration, or closed, from blunt trauma. But honestly, whether you're dealing with an open fracture or a closed injury, your #1 priority is safety. Always immobilize the neck and spine immediately until a spinal injury is completely ruled out. Also, make sure to withhold any sedating medications during the acute phase. Why? Because you need to accurately assess any changes in their LOC. And of course, rigorously assess for battle sign or any clear drainage coming from the nose or ear. We're actually going to talk about why that specific fluid is a huge deal in just a moment.
Let's transition over to Section 3, Meningitis.
Meningitis is a severe, infectious, inflammatory process of the central nervous system. These patients are often going to present with a fever, severe headache, and a really stiff neck. You might even see positive Kernig's and Brudzinski signs. If you suspect meningitis, get ready for a lumbar puncture, followed immediately by antibiotics. You'll need to implement respiratory droplet precautions and keep them going for at least 24 hours post-antibiotics. Also monitor closely for complications like SIADH, which causes dangerous fluid retention, and stay highly vigilant for a purpuric rash. If you see that rash, it can indicate a life-threatening meningococcal infection.
All right, our 4th topic covers Section 4, Seizure Disorders.
Seizures are characterized by these excessive, unorganized neuronal discharges in the brain. If a patient starts seizing on your shift, your response has to be practically automatic. Ease them down, turn them on their side to prevent aspiration, protect their head, and meticulously document everything, like the presence of an aura right before the event as well as the exact time and duration. And here's the absolute golden rule. Never, ever place anything in their mouth and do not attempt to restrain them.
And our final pathology before we get to the challenge is Section 5, Hydrocephalus.
Hydrocephalus is an imbalance in cerebrospinal fluid that increases ICP. In infants, you're going to see this manifest as bulging fontanelles, dilated scalp veins, and those characteristic setting sun eyes. But in adults or older children, you'll see headaches right upon awakening, along with ataxia. Now, this is frequently treated with a VP shunt. Postoperatively, you want to keep the patient flat on their unoperated side. This prevents a rapid reduction of fluid. However, if you see signs of increasing ICP, you need to immediately elevate the head of the bed 15 to 30 degrees to get gravity working for you and notify the surgeon right away.
Which brings us to Section 6, the challenge.
Listen closely, future nurses. It's time to put all that knowledge to the test. We've got 5 rapid-fire NCLEX-style scenarios based directly on what we just reviewed.
Here we go. Question 1. What is the earliest and most reliable indicator of an improvement or deterioration in a client's neurological condition? You've got 5 seconds on the clock. Think about what changes before the vital signs do.
The answer is the level of consciousness, or LOC. Assessing this early and accurately can literally save your patient's life. A subtle shift in LOC is going to happen long before severe bradycardia or abnormal posturing ever sets in.
Next up, question 2. A client with a head injury has clear fluid draining from the nose. What is the priority nursing assessment? 5 seconds on the clock. What specific assessment must you perform on that drainage?
You have to test that drainage for glucose. If that clear fluid tests positive for glucose using a Regent strip, you are looking at a highly dangerous cerebrospinal fluid leak. You absolutely must notify the healthcare provider immediately.
Moving right along to question 3. What specific isolation precautions are mandatory for a client admitted with suspected bacterial meningitis? 5 seconds. How are you protecting yourself, your other patients, and the whole unit?
You must immediately initiate respiratory droplet precautions. And just as importantly, you have to keep them strictly in place until at least 24 hours after that very first antibiotic dose has been administered.
Okay, question 4. This one's a classic NCLEX trap. During a tonic-clonic seizure, the client's jaw is clenched. What airway device should the nurse insert? 5 seconds, your patient is actively seizing, jaw is tight, what are you inserting to protect the airway?
The answer is absolutely none. 0. You never place anything, not a tongue blade, not an airway device, nothing, into the mouth of a seizing patient. Your only job is to clear the area, gently turn them onto their side as a unit to protect that airway, and time the event.
And finally, question 5. Post-VP shunt placement, the nurse notes decreasing LOC and bradycardia. What is the immediate positional intervention? 5 seconds to answer. Your post-op patient was lying flat, but now they're crashing with signs of high ICP. How do you position that bed?
You immediately elevate the head of the dead 15 to 30 degrees. You need gravity to help drain that fluid through the shunt. Honestly, you did fantastic today. Just remember, your clinical vigilance is the ultimate barrier between a minor complication and a major catastrophe. Review this explainer, trust your training, and ask yourself, what other life-saving assessments will you master next? Keep studying, and I'll catch you next time.